Welcome to the next session here, which will be on new LAA devices. And we have a new iteration of the Amulet device, the Amulet 360, and there's a study already published, the Veritas study, and Xavier, you were part of the study and probably the European implanter that has most experience with the new Amulet 360. So please tell us about your experiences.
Thanks, Erik. So you're right. I mean, like the initial results have been published. But anyway, like this session, it's a case-based session. So I will focus more on practical stuff and more device features, which I think that it's interesting. You know, you can just check the results of the Veritas study at 45 days. They're really good with, extremely, good safety and efficacy outcomes. So basically, what's new and what's the same in, Amulet 360 compared with the standard Amulet? So it's the same. So we have the same, mechanism. It's a dual sealing mechanism with lobe and disc. The lobe, needs to be sized and needs to be put in the landing zone so that disc will cover, the ostium. And the objective of the device is just to achieve complete sealing. We have this flexible waist that it's the same between lobe and disc, and we have the same sizes, 8 sizes, from 16 just to 34. And then we have the ability to do, like some different techniques, implanting techniques like the sandwich. We will see a case with Amulet 360 of this. And we can use the steerable or the fixed curve sheath. What's new? So basically, like things that probably we were all requesting in Amulet. So now we have an inverted distal end screw and a marker band. And we will see that that allows, just to steer freely. And of course, it's atraumatic. Then we have the distal shape of the lobe. It's more rounded. So this will allow, just more forgiveness when implanting. It's more, I would say, reliable and you can anticipate the position. It's very stable. Then we have, instead of 1, 2 rows of stabilizing anchors. Like those anchors are a little bit, just more distal. So when we form the ball, we have just to keep in mind, instead of 12 and 14 French, now we have, always to use the 14 French sheath. And of course, there's going to be like a steerable or fixed. And that, sheath can be reused for different devices. If you need to change for any reason or you're doing 2 captures, according to the IFU, you had to change. Now you don't have to change, so you can just use the same sheath for different devices. And the sizing chart is going to be different, and that's probably another relevant information. So again, and going just point by point, which I think that it's interesting. So that probably it's one of the major changes. So now we don't have like distal screw, protruding distal screw, that can be seen like a safety issue, which is a safety issue. But for me, other than that, which is very important, that allows to rotate, especially to counterclock, in a more coaxial position. I don't know if, for the ones that use Amulet, sometimes if you're a little bit distal, or if you're not so distal, make that counterclock. It's not so easy because that distal pad gets trapped into the trabecula. And then you want just to rotate anterior, and you cannot rotate. So with this, with Amulet 360, that's going to be like really easy. Second thing, it's this, doming, this rounded distal lobe or distal part of the lobe, which will adapt more to the anatomy of the appendage. Then we have safer, redesigned anchors, are shorter and just more rounded. So in theory, less risk of having pericardial effusion. And we have a double row just to, I would say, ensure stability. So now it's a more stable device. And you can tell also, because, when you deploy the lobe, it stays, in place much better than the standard Amulet. So I will show, and I put case 2 because that means that it's our actual case 2 with Amulet 2. Just to, I would say, to show that there is, for an Amulet user, there is no learning curve. I mean, there is there are some considerations in terms of sizing, in terms of choosing the device, but to me there is no learning curve. It's actually, easier to use Amulet 360 compared to standard Amulet. So this is a standard appendage, let's say ELAACC. I don't know, what do you think about the ELAACC? It's ELAACC 1, I think. With Laura, we always make that exercise. Apart from sizing, we always measure the ELAACC in the table, and then we put it in the report, because I think it's a good exercise to integrate, the ELAACC score in our minds. But this would be more or less ELAACC 0, maximum 1, but I think it's 0. And then here you have a landing zone of 17-18 and ostium of 22-27. Now measuring the ostium will be much more important with Amulet 360, because we were going to be able to select probably 2 or 3 sizes. So sometimes if we have like a large ostium, we will go for the largest, because the lobe will adapt just to different sizes. So here is the transeptal. After the transeptal, in our institution, we always measure the LA pressure. In that case, the LA pressure was good. So then we don't remeasure, and the landing zone is good. It's in a normal, fluid condition. And here you can see the way that we work. We always work with MPR for, the approach of the appendage, and also for the implantation of the appendage. Always, in the bottom, you see that you have the 2 planes where you can just advance and rotate to get the perfect coaxiality. So this is the delivery sheath, and then the pigtail. We don't usually do injections, but this was part of the protocol, so we did it. And you can see, you can confirm that this is a standard appendage. Landing zone, it's a mean. Now, we size based on the mean diameter. So the mean diameter is 17.5. So here we have 2 options. I'm pretty sure that for the Amulet users, if you have a mean diameter of 18, you would go for a 22. Because it's 4 millimeters, of oversizing. So now with Amulet 360, we can go, beyond that, and probably we need to oversize a little bit more. Amulet 2 here, it's Amulet 360. 25 would be probably not the right option, but like a good option, especially because we're going to have a disc that we're 100% sure that will cover. The disc will cover, because it's 32 the disc, and you can see here that we have a maximum diameter of 27. So 32, a disc of 32, I think that would be like really, really good in this case. And here you can see like the way that we open, we unsheath. Now the ball, it's not, like just an actual ball. It has to be a little bit less than a ball, because, like the first row of anchors will show up, and then very, soon. So in this case, maybe this is just too much ball, and we will, maybe just generate less ball, like a pre-ball, and then we'll start to rotate counterclock. You can see how easily it rotates, because there's no distal end screw, and there is no contact of the hooks with the wall, and that's one, for me, of the main advantages of Amulet 2, just the capacity of rotation. And then the deployment, it's extremely controlled and has to be extremely slow. As you can see here, it's not moving at all. Now the rows of anchors are engaged, and now you see it's not moving at all. And this is something that doesn't happen with Amulet 1 or Amulet, standard Amulet. It will generally pop out. So here you can see that it stays stable. So always with MPR checking the formation of the disc. And here, the stability test. Here, the signs of stability are the same: close, circumflex, lobe orientation, separation, and ellipticity. But there are like 2 other signs. That is the distal doming of the lobe, and then the disalignment of the distal marker and the waist. When you see that they're not aligned like this is, like an indirect sign of stability, because that means that, there is some tension inside. So here you can see the result is very good. We inject, no leak at all. This is one of, the good things about the device. The sealing performance, showing Veritas study, it's really, really good. and then we discharge the patient without any problems. And going, just to the second case that I'm showing, it's a third case, the actual third case. So the third case was a chicken wing. Chicken wing probably that required a sandwich technique. So we test the device, in a more challenging situation. Here, the standard, as you know, in the sandwich, the standard measurements of the landing zone maybe are not appropriate, but in this case, the landing zone would be more or less the ridge area. So we need to go more into the chicken wing. So the ridge area was around 15, and inside the chicken wing, so we had diameters of 17, and like just the space, of the chicken wing was quite large. So again, we check, for LA pressure, which was good. So the landing zone again, it's I would say like 15. So we went, for oversizing of 4, 5, 6 millimeters. And in this case, so this is the chicken wing, and this is the injection, as you can see here. And we, make this counterclock rotation. And in this case, we went for Amulet and 22. Okay, and you can see that we are doing the rotation. Again, I want just to highlight the easiness of rotation of this device, so you can just counterclock like really easily. And again, you will see how, nicely opens and how stable opens. Like no much change here. Slowly, always, you need to go slowly, and you can see that will open, and it will stay inside the appendage. Look at the echo, the bottom right, how, the lobe stays inside the chicken wing and, beyond the ridge. So here we open the disc. The best sign of stability is the distance between, the lobe and this. You see that distance is telling you that the lobe, it's inside the chicken wing, and the disc stays outside. So, this is probably the most powerful sign of stability that you can tell. And again, in the injection, there was no contrast at all and no complications. Just to me, Amulet 360, it's, a better device compared to Amulet, a much better, I would say, device. It's atraumatic, it's more conformable, and requires probably larger oversizing, so that it's more forgiving, and we can just select different sizes. The lobe keeps the intended position. There is no pop-out effect of the Amulet. 2-3 sizes fit. Seems to be very stable, double anchoring. And the concern with Veritas was the roll for DAP for 6 months, but in the first 45 days, it behaved very well. So thank you very much.
Thank you very much, Xavier. Questions for Xavier for the new? Yeah, Joe?
Yeah, excellent, Xavier. I have a question regarding the sizing. So do you modify your sizing chart for the Amulet 2? You recommend to size based on the mean diameter. So is it different than with Amulet 1, especially in eccentric appendages?
It's a different sizing chart. So the official sizing chart is different. So, and actually they offer like almost 3 sizes for each measurement, no? And then you put in the diagram, in your selection, diagram, also the size of the ostium. And then, based on both, you end up selecting. But you use the mean diameter, not the maximum diameter, and that's a difference compared to Amulet. Yeah.
Xavi, another question about the anchors. There are 2 rows of anchors, and how many anchors are in each row? 8 in each row? How many?
I think that it's the same number. I don't know. Maybe the engineers of Amulet. How many? It's the same, no? The number of anchors. It's double, same number. Yeah.
Yeah. And what about there is a funny shape of the anchor, that there is a loop in that anchor, and then there is, because on one of your pictures it was that there is a loop and then the distal part of the anchor. Why it's like that? Well,
I don't know if, like that picture, it's actually telling you, the reality. The thing, the global concept, it's like really very similar to Watchman Flex. So it's like the typical anchor that it's rounded, parallel to the lobe. and, in theory, more traumatic. Instead of Amulet, that the angle was towards, like I would say, like just external structures. Now it's more parallel to the lobe, and, in theory, that would be safer. I don't know exactly
but Marek,
the angulation.
I think what Marek means, it's you have these hooks, yes, but it's not laser cut as a Watchman flex, for example. So this is sutured into the, correct me if I'm wrong, but it's sutured into the lobe, the nitinol structure of the lobe. To be honest, I still dislike that a little bit more than laser cut hooks, which is really even more atraumatic. I think they did their best to make it as little traumatic as possible. But indeed, it's still a woven-in structure, a sutured-in structure in the nitinol. It's not a laser cut structure.
Can I just add to this? I think one of the issues with the Amulet so far was that it was not possible, or at least I was reluctant, as many others, to give NOAC afterwards, because you had this increased sign of pericardial effusion, particularly in that combination in the Amulet IDE. Now, do we trust this new design to also give these patients NOACs? For example, if we are in fear of DRT?
Yeah, definitely. I think that well, honestly, I was not, like just withholding the NOACs with Amulet in any situation. So we have the Adala, and it was almost, like most of the patients Amulet, and we have those. It didn't show, like an increase, but definitely I think that, the redesign of the anchors will impact in a lower rate of pericardial effusion. So yes, yeah.
I don't have that data yet.
I mean, this is maybe common sense, because my biggest concern was always we had the hooks at the Amulet at the level with the highest radial force. So I think the concept of making it a little bit more bowl-shaped in the distal part and having the anchors a little bit more towards the inner side, I think this is a really good concept, because, I mean, it's a big concern. Yeah, we shouldn't have perforations. And I think it's not always because of the device design, but if the implanter is not taking care of that, it's getting even worse.
Okay,
I have a question for you, Xavier, because I feel that with a disc-based device, it's extremely important that the disc ends up in a very good position and really do the job of sealing. And now that we have a lobe for the 360 that is more soft, it's more conformable, rounded, we don't have the distal screw, why not go completely from the ostial measurements and imagine where should my disc be, and then start the sizing from there, in order to really be confident that your disc ends up and really seal in a good way?
Well, I like your approach. It's a very extreme approach. I would be happy if, like in the sizing chart, they, integrate the ostium, just to make that decision. And that would be, the first step. But I think that might be an idea, no? Like just to go from outside to inside, yeah.
But at least to bring it into the consideration about device sizing, because we always talk about the landing zone, and as you already said, there can often be 3 different sizes to choose for a given landing zone with this device.
The only thing that, well, like just that measuring the landing zone, it's just not only for the size itself, but it's also for the orientation. It changes a lot, if you put it more clockwise or counterclock. So you will always have just to consider, the landing zone as probably, one of the most important things. But I fully agree that we should integrate both, because it gives power, to the message of dual sealing.
Yes. Okay, thank you. I think we have to move on. Thank you, Xavier. And I'm going to introduce Erik. He's going to talk about the Watchman Flex Pro device.
I think the Watchman Flex Pro is probably familiar to many of you already. It has been launched in many countries now, and I guess you have, most of you, experience now with the device. The problem that we have with LAAC, or one of the challenges, is still DRT, and it's not very easy to treat DRT, and it's also difficult to prevent DRT, and you know all the regimens that are out there, and the dilemma is, of course, if we do a heavy post-procedural antithrombotic treatment, we will just increase bleeding rates in the patients that we have already that are at high risk of bleeding. So the idea with the Watchman Flex Pro was to try to build in some of the anti-thrombotic properties or resistance in thromboresistance into the device itself. And for that, there was produced or investigated a new fluoropolymer coat in order to try to increase the resistance here. And that's the main idea with the device. But at the same time, we also saw an expanded range of devices. So we now have the 40 millimeter device, so we can cover up to at least 36 millimeter landing zones with this device. And they also added some fluoroscopic markers, so it's easier for us to see the shoulders and where the maximal diameter of the device is. The whole concept around reducing the thrombogenicity is related to the properties of the membrane that makes albumin bind to this coating very rapidly, and by having a cover of albumin of the membrane that will reduce platelet binding to the surface of this coating. And from animal studies, it has been shown that this also reduces inflammation, thrombus formation, and also it enhances ingrowth of endothelial cells. So when we put in a device, there will be activation of both platelets and of the coagulation system, and in some way we will get a microthrombus layer, which is the normal course. And I mean, if we then have risk factors present for DRT, and we know a lot about risk factors now, then we risk the development of having device related thrombosis. It's also important to be able to discriminate between this initial ingrowth or this initial microthrombus layer or thrombus layer and discriminate to real thrombus. And based on studying post-implant surfaces of the Flex and the Amulet device, we have come up with this classification where we can accept up to a layering of 3 millimeters. That is something without treatment will regress and be flat again. We believe this is completely beneficial healing, opposed to when we have large masses on the device and pedunculated masses. So we talk about those gradings of HAD and of real DRT, that is grade 2 to 3 HAD, and I think you're all familiar with this classification now. So is this new coating actually working on the Watchman Flex device? And we do have some data out there, but not the full data yet. But this is also NCDR data on Watchman Flex compared to Watchman Flex Pro, and it's 45 days DRT rate, and you can see that there's actually very little difference, actually a little bit more DRT with the Flex Pro device, but on the other hand, you can see that also the antithrombotic treatments were different between the two devices here, with more anticoagulation for the Flex compared to the Flex Pro device. But there is a systematic study there evaluating HAD DRT, which is the HEAL LAA study, which is a 500-patient post-market study of the Watchman Flex Pro, and the data will be presented at HRS in few weeks, so we will have the full data sets, and we'll be able to see if the Watchman Flex Pro really also works in real life with a reduced DRT rate. We did some small studies also both on the Flex and Flex Pro by evaluating what was going on the surface very early at day 14, again at day 45, 3 months and 12 months. And we kept those patients on a very minimalistic regime with only single antiplatelet therapy with aspirin 75 milligrams per day. And in this way, we could in some way study the natural history, what's going on when we put in a device. And for the Watchman Flex Pro, this is the very typical healing response that we saw. At day 14, yes, we had some kind of layering on the atrial surface, probably a microthrombus layer, and with time we saw resolution of this layering, and from animal studies we know what's going on is initially fibrin thrombus, and then it's gradually exchanged with ingrowth of cells, and in the end a single layer of endothelial cells. We did also use the 40 millimeter device among this patient series, and this is a case that is interesting both because we used the 40 millimeter device, but also this was a patient having a very high risk of DRT. He was 81 years old, having a hematological disorder with thrombocytopenia, and he actually before LAAC demonstrated that he could form LAA thrombus in the LAA that we had to treat with low molecular heparin. And he was part of our study. Due to low platelets, he got infusion prior to the procedure. And you can appreciate here on CT the very large dimension and also a lot of slow flow in this appendage. And this is early and late acquisition CTs. And even on the late scan, you can see there's still some shadowing in the appendage, and we did an extra here transesophageal echo to be sure that it was not thrombus, and it was not thrombus. It was just extremely sluggish flow. And the dimensions here: maximal diameter 35 millimeter, and this is just quickly showing you this very large appendage here, and the 40 millimeter device chosen to cover this landing zone of 35 millimeters, and the implant control angio before. And you can see here also the use of the radiopaque markers. Of course, on the CT, you plan where to put your C-arm, and you can do the final adjustment so you are completely sure that you are perpendicular. I'll go one back, that you are perpendicular to the device. And here you see a small shoulder inferior posteriorly, and it's helpful to have this C-arm readjustment so you can precisely measure how much your shoulder is protruding out to the left atrium, and here it's within an acceptable range. And just all our cases are done by eyes, and this is the appearance of eyes with this patient. And also interesting here, you can see at the early scan, 14 days, there is a quite extensive layering, which is not smooth on its surface. So this is grade 2 head. So this is something that resembles real DRT. But due to this patient's bleeding ability and the very early scan, we chose not to treat and just kept him on kept him on low-dose aspirin, and you can see on the serial images here, it just resolved over time, just having aspirin on board. I cannot publish or give you all the results from this Flex Pro CT study because it's going to be presented at EuroPCR. There are data out there, a small series with a 40 millimeter device, 9 patients from an American center, and actually 3 of the cases were failed cases with the 35 millimeter Watchman device, and with the Flex Pro 40 millimeter device they obtained successful closure with this in 9 cases, including the 3 failed cases, and only very small leaks here in this series with the large device. So it is a new option for us to also be able to close those very large appendages. And again, this coding also made Boston do this trial on post-procedural antithrombotic treatment with the Watchman Flex Pro device, the simplified trial where we in one of the arms have aspirin only, this is SAPS, and then we have half-dose DOACs, and then we have the third arm with DAPT. So it has really changed the regimen for a Watchman device, coming from all anticoagulation plus an antiplatelet, and now we are down and comparing with the Watchman Flex Pro here, aspirin with half-dose DOACs, and all patients have been enrolled in this trial, and I'm not completely sure, but I hope we see the results already at TCT, maybe at a little bit later stage, but that will be very exciting for us and have guidance on post-procedural imaging. So, and this is the result with the 40mm device here on the CT. So thanks for your attention.
So thank you, Jens-Erik. Any questions from the audience first? If not, then I want to ask you how to use these markers indeed, because I think most people in the room, if they have the Pro, I bet they hardly use those markers. So you show there a little bit how to use it, but I think that's maybe the key also. Then you almost need your CT info. You can calculate your best fluoroscopic angle. Or can you guide us a bit how you use that, how it could be useful? Yeah. And what do you do if these 3 markers are not in a line? Yeah. What is your conclusion then?
If you really do the pre-planning and you completely predict where the device will land, you will already have chosen a C-arm where you see them aligned, so that is very good. But that is, of course, not always the case, and if you don't have that situation, you can readjust your C-arms so they are in line. Instead of, without the markers, we had to look at what we call the big bubble inside the sheath, and it could be some way a little bit difficult to see exactly where's the big bubble. So instead of looking at the big bubble less defined, now we can look when we backsheet or push forward, we can have a good measure on where is actually the shoulders and when will they land. So that's one advantage. The advantage also, when you have this shoulder protrusion, you can get a reliable measurement if it's less than 1/3 or more than 1/3. And then I think there's a new option with the steerable sheet, because the steerable sheet can be used, I think, in 2 ways. First of all, you can, before you deploy the device, you can align the sheet to the axis of the appendage, so you get very coaxial. But in some cases, you can also use this we call mid-deployment steer. So you partially deploy the device, and when it's partially deployed, you adjust. For instance, if you want to have a more steeper angle to your device, you clockwise rotate or you steer the steerable sheet in a clockwise direction to get another angle of the device. And there the markers are helpful, because they will, when you reach, you should start your steering just before you have the markers deployed. So when you start to see the markers being very near to the tip of the sheet, that's when you can start this mid-deployment steer.
Okay, that's very handy. I mean, it's really true. Look, I'm training all the time fellows. I'm hardly standing with my hands as a first operator doing my cases. So the thing is, with that steerable sheet, I learned that if a new beginner has the steerable sheet in hands, he has so much focus on that finally he can flex or unflex the thing that he loses a little bit the focus on having just a simple counterclock on his sheet itself. And that's still the primary thing to do. to be honest. And it's good what you say there, also there, so these markers are indeed useful to look, is there parallax in my device, yes or no, but also that I even didn't have so much focus on myself, so it's good to hear that. So when the markers are getting close to the tip of the sheet, that's indeed, you do it almost as a two-step. So you have your counterclock, your typical counterclock on your sheet, which you shouldn't forget to do. And then you deploy your device, and it's kind of almost midway, apparently then when the markers are almost to the tip of your sheet, then you can start of thinking, do I give a little bit of flex or unflex on my steerable sheet? Yes, so that's a good tip, I think, and it's important. I'm going to have more focus on that myself too. Okay, thanks. There was a question, I thought, from Marek, no?
You have already said what I want to say, but even if you are not doing pre-planning of the CT, these markers are extremely helpful because I adjust my CR angle to these markers during the procedure. So even without pre-planning, it's extremely helpful, these markers to be like in TAVI, well, Marek, if you want to avoid parallax, yeah?
True, but on the other hand, I agree, but you do your implant and you correct your C-arm to get them in line. But of course, it could be that your device is completely out of axis, and then you correct your C-arm, and then you inject and you say, yeah, it's an axis. But whereas, I know not everybody does CT, but if you have the CT info, you really can get into that angle where you think my device should be an axis, and if it is an axis, it confirms your really perfect coaxial with the appendage, in a way. Okay, thank you, Erik. I'm going to introduce here myself, it seems. No, I'm going to start by disclosing that I have no experience with the device, but I will still present. And I'm going to keep it relatively short. I think it's going to be more interesting to hear maybe, again, I have no experience with the device, so to hear on the audience and I guess there's people from the company here also in the room, to hear some feedback, what is the idea about the concept of this device. So this is the Zenith LAAC system, and what is it about? So it's a 19-hole braided scaffold, as you see on the top, which should be very compliant, apparently. And then it has independent anchors, which can be deployed in a second step of the procedure. You have a self-closing pad-covered conduit, so there should be no exposures to metal. That's for the DRT rate to keep it low. And then you can actually also, conformal, you can do a contrast flush channel, so you can have the device in place, give contrast internally in the device, and see whether there is a leak going into the left atrium, yes or no, before the release. There's currently, they're working on 3 device sizes, 22, 28, 35. There was only use of the 28 millimeter in this first-in-human small series of 10 patients, where I'm going to show you the results from. And then apparently, I have not had it in my hands, of course, but it seems like a TAVI-inspired handle and steerable sheet for precise control placement and deployment. So here is an animation, so you can bring this scaffold or deliver this scaffold on the position where you want, optimize it as many times as you want. You see it's anchor-free, so you can really automatically reposition this device, and then when you're happy about the device position, and when you've confirmed there's no leaks, you kind of come second, in the second part of the procedure with the anchors. So here you can see it again, it's controlled scaffold delivery. And then when you're really happy about the position, if you confirm there's no leak, you can deploy these independent anchors. So here you see this is in a bench. You see it on the left side, how it's deployed. So this is first this scaffold only, yes. You can reposition this. And then you will come out with these anchors as well. You will see it, I think, on the fluoro image. Or it's on the next one, yeah, here. So this is then the contrast flushing inside in the device. You see here, for example, on the left-hand side, you inject the contrast in the device. You confirm there's no leak. And when you're happy, then you deploy the anchors and you release. On the other hand, keep an eye on the right-hand side. So you give some contrast within the device and you clearly see there's still some remaining gap and some leak. So then you have the possibility to reposition your device and try to get a more optimal position. So this video should also run. Yeah, here you see very clearly how these hooks come out, these anchors come out here. So when the device is in place, they come from the central tube and they deployed. Yeah, here you will see it. Yeah, here these anchors come out and then you anchor the device safely into the appendage. So they've done 10 cases. This is a prospective multi-center open-label single-arm trial done in Australia and New Zealand. You see the people involved in there. One of my former fellows, Matthew Brooks, I see, is also involved in this. And then they've done, as you see, the regimen on the right-hand side, post-procedure, DAPT or oral anticoagulation, 45-day TEE, and then a 6-month DAPT to aspirin, and a 12-month CT. So, of course, 10 cases. This is the selection of cases. You see there was prior cerebrovascular events in 9 out of the 10 patients. 6 patients were actually breakthrough strokes, and then 2 patients with intracranial hemorrhage. Of course, you see here the results were very good, 100% safety. There was no events, to be honest, in this small series of 10 patients. No DRTs as well. And then this is maybe, if I go back here, you see also the device implantation time. Of course, it's the first time they do it, a small series of 10. Device time, implantation time is 35 minutes. Fluoroscopy time may be a little bit long, 22 minutes, but okay, it's for a first in human series, maybe, yeah, understandable. So 11-minute fastest deployment time. The other things, yeah, the range of compression is like the other devices. I would say you aim typically 10 to 35% kind of compression, which is normal. These are all the 10 anatomies, so they were not too hyper-selective, it seems, in their, they tested in different anatomies. And then these are the longitudinal follow-up outcomes. So at 45 days, all implanted patients had closure of the LA, no DRTs were seen, and at 1 year CT imaging, no changes from these 45-day echo images. Device was stable, there was neo-endothelialization and no DRT again. There were 2 bleeding events, but these were bleeding events in patients who had a previous history of blood transfusion dependent anemia. So this has nothing to do with, I think, the post-treatment even. And then the anticoagulation status, that was all patients were successfully transitioned to single antiplatelet therapy. So this is the final slide on it. You see also the ECHO image, how it looks on echo. So successful first in human results, same-day discharge was feasible. 2-stage deployment, which they say enhances repositioning and flattens the learning curve. So as you saw, the device, it's a braided, very conformable scaffold, and then these 2nd-stage dynamic anchors to adapt to diverse anatomies. There's no exposed nitinol. They also didn't have any DRT in this small series. And then they have that contrast flush check, whether before final deployment and before anchoring the device in, which is really nice. And they're planning, I don't know the real plans, but larger 2026 trials in the US and outside US is planned for FDA pivotal trial approval. So, thank you.
Thank you, Ole. I like actually the concept where you can put in the scaffold and you can struggle to get a good position without having the anchors exposed, because with most of the devices when we recapture, we risk trauma to the LAA wall, but with this it's very soft and there's no hook, so you can really work around and get the very nice position. And the other feature I like is that you can do intra-device angio, and you can be quite confident that you have a completely seal before you come in with your anchors. So I think those features are quite nice.
Yeah, absolutely. Yes.
But I believe that the length of these anchors are fixed in each size, and if you have more compression, of one device, then the anchors will protrude a little bit more in the LAA wall, or?
I don't think so. I had that same question to the company, but it seems like they are actually pretty flexible as well. So they must have some power, of course, to get out. But I mean, if there's more or less compression, indeed, it's a correct question. If there would be 10 or 30% compression on your device, whether these hooks are, but they seem to be similar, sticking out. Yes, they adapt. They're flexible, so they will not protrude more normally when you have more compression on the device. Shouldn't be.
Because
they can bend even a bit. They are relatively flexible. I don't know if there's somebody from the company here present. They maybe are willing to comment on it. I had it in my hands once. It seems relatively flexible. It seems not to protrude more if there's more compression, no?
Yeah, no, that's absolutely correct. So probably 3 years of work was done just developing the anchor system alone. So there's probably 1,000 prototypes before we've gotten to that final one. But there's actually a stop on the anchor system. So the anchor system can only protrude to 0.8 mils into the left atrial appendage tissue, no matter how much force is put on them. Mm-hmm. So you can actually physically press it with your finger and it can't penetrate any deeper, because there's a physical barrier stop on it that interacts with the braid to prevent it from going.
Yeah, because it comes from inside the nitrinal braid, and then I don't think it can stick further out. So it will always be the same kind of distance sticking out. The anchors will always have the same length, seems. Yeah.
I also have a question, regarding the anchors. So, because sometimes, just we cannot be coaxial because the line of hooks are at the same point. So these anchors are coaxial to actually the device itself. So I mean, in one side, the anchors anchor more proximal to the lobe, and maybe on the other side more distal. So are coaxial the anchor line and the device itself?
Yeah, so it's one of the, so with the device that we'll be bringing forward now, it's a steerable sheet system. So, and the anchor system allows for coaxial alignment. So once you're positioned within the left atrial appendage with the scaffold, it automatically allows for coaxial alignment of the anchor system using the steerable sheet system.
Can you give us there's a further question.
Yeah, it's also concerning the anchors, because obviously this is a very new concept and interesting. So I had the impression the anchors are pretty long, and my concern would be that the anchors have fractures over the time. Did you observe something like that?
No, we haven't seen that. Obviously, they've been tested to the same protocol that we test every other part of the element of the device, so 100 million cycles, and we haven't seen any damage to the anchor system.
Maybe I also wouldn't be that concerned. I mean, even let's say after a year there would be a fracture. Normally that thing should be grown in a way. Yeah. So I don't know.
So we've seen in our preclinical studies at 45 days, there's been pretty thick pannus across the face.
Can you give us just final question, a very realistic timeline? Now we show it here. When do you think, and honestly a realistic thing, when do you think we may see this in Europe? Not first maybe in study, but also then commercially. What is a realistic timeline you have?
Realistically, we're aiming to be in studies in Europe early next year.
So early 2027, yes. And then you're going to run a pivotal trial. You will need a trial of 1,500 patients, I think, roughly. Yeah, so that's okay.
But that'll come obviously after. So the next stage will be a large feasibility study, OUS, and an early feasibility study in the US.
That's going to cost you 1-2 years, 1 year follow-up. So then earliest 3 years or so, 3.5, 4 years before commercial, if everything goes well.
It's not a short process.
No, okay. No, but good. All right, good. Thank you. And I think then we invite Sergio Berti, yes? No? Oh, Luigi. Okay. So yes, please join for the conformal the CLAAS device. Yes.
I am Luigi Pastormerlo and come from Massa, and I will present to you our initial experience with the Conform CLAAS device, and I will show you a nice guided case that we perform in our CAF lab in Italy. Briefly, some technical points about the device that make it unique and that can account for some specific use. are, the first one is about the composition. This device is made by a foam matrix body on which is embedded a compliant nitinol endoskeleton. On the atrial surface, we have a polytetrafluoroethylene dual-layered cover that is connected with a flexible tether. So the consequence is that we do not have exposed metal on the left atrium. And this has two main objectives that are to reduce the thrombosenicity and to make a perfect sealing, since the foam has a perfect conformability into the left atrial appendage. From this point, we derive another point, that is that the sizing is very simple, because we have only two sides of this device, and one size, the regular size, that is 27 millimeters, covers for about 90% of left atrial appendage anatomies, because it covers an ostium range that go from 10 to 33 millimeters, and we need just to have a mean diameter that is less or equal to 25 millimeters. And given the foam conformability, we can cover a very elliptic anatomies for the left atrial appendage, ostium and landing zone. The third main advantage that we have with the use of this device is related to the delivery sheath. We have a delivery sheath with two steering planes, two orthogonal steering planes that have the main objective to gain the best implant orientation and to permit us for a perfect implant into the left atrial appendage, as you can see in the cartoon. At our institution, we use intracardiac echocardiography, usually two-dimensional intracardiac echocardiography, and this has two main objectives. The first one is to avoid general anesthesia. The second one is to have a perfect imaging, because the nearest you go to your target of interest, the best imaging you may have. To perform left atrial appendage with intracardiac echocardiography, above all if two-dimensional intracardiac echocardiography, we think that pre-procedural three-dimensional evaluation, better if with CT scan, is mandatory to have a full evaluation of left atrial appendage anatomy. In this specific case, we have a whole tail about morphology, whale tail left atrial appendage anatomy, and with a circular landing zone, a mean diameter that is that permit us the implantation of the size of the device, because it is 23.5 millimeters, and we have some trouble about the shortage and the functional depth of our left atrial appendage, because it is 11.5 millimeters. So we have a moderate, difficult case according to the ELAACC classification, as we have short depth for implantation. We perform transeptal puncture in a common inferior and posterior position, guided by the intracardiac echocardiography, and then to get a perfect imaging of left atrial appendage, as mentioned in the morning, we have to go with the probe inside the left atrium, and we usually use this technique. We place two guide wires in the left upper pulmonary vein. We align our probe with the two guide wires on the same transeptal point, and then we get in the left atrium. Once we are in the left atrium, it is fundamental to have at least two different orthogonal views of the left atrial appendage. The first view is from the left upper pulmonary vein. It resembles a cranial fluoroscopic visualization of the left atrial appendage, and it approximates 45 to 60 degree projection of transesophageal echocardiography. The second view that may be a little more complex to obtain, but you can obtain after a moderate learning curve, is the so-called supramitral view. So you are on the anterior leaflet of the mitral valve with the probe, and you see the left atrial appendage from down to up. And as you can see, this view resembles a caudal view from fluoroscopy and approximate 135 projection from transesophageal echocardiography. Then we place the probe in the mid-left atrium, and we follow all the steps of the procedure. We selectively enter the left atrial appendage with the pigtail, and then we start with the release of our device. You can see the orientation of the delivery sheath. We push the device inside the left atrial appendage. The distal end of the device is very soft because it has a sort of a foam bumper. And we follow this with echocardiography. This was the first release. It's a bad orientation, two proximal device, no sealing of the left atrial appendage, as you can see also from the echo visualization with a leak. Then we move for a different orientation of the delivery. We move more forward with our implant, and we release, we place the device in this position. At this stage, we check also from an orthogonal view. So this is the supramitral view, color and without color. Then at this stage you have to release the tension, so you have to release the tether from the pusher, and to assess the position and the stability of the device after this release. In the echocardiography, echocardiography you can see the contour of the tether and the detail of visualization from the supramitral view. Then in this condition of released tension, you perform the tag test, so you check for the stability of the device, and you evaluate all the criteria that in this case are with this acronym: P for position, O for orientation, S for sealing, and T for tag. And then you release the device with this magnified final result, and with this result at echocardiography when you have completely released the device from the tether that kept it attached to the delivery, to the implant system. So the device is very interesting because it has a high conformability to different anatomies. It may give a perfect sealing. The delivery may be simple, and the orientation with the delivery catheter is very, very useful for this. And the imaging of this device is very good, also with eyes and with no need for general anesthesia. And the promise to reduce thrombogenicity has a clear background by the total absence of metal exposed to the left atrial surface, to the left atrium. Thank you so much for your attention.
Thank you very much, Luigi, for a very, very nice case. We have only time for one or two questions or comments because we all need coffee now.
Yeah, one quick question to any of you. I mean, 3 of the 4 devices that we have presented here are single lobe devices. What do you think is going to be the future, this type of devices, or still disc-based devices? Any of you?
Yeah, I don't know. I mean, look, I like to make the comparison with TAVI field. I mean, a single device is like the Sapien of the devices. Yes, it's super easy, it's simple. I mean, it's teachable to everybody. It's like, it's very easy. Whereas a double component device, it's like a self-expanding TAVI device. There's just more learning curve. To become really, really good at it, you have to have more attention to more things, so it's less forgiving in a way. So that's how I look to it. Single device is easy. Double component is always a bit more difficult. I think to get the optimal, perfect result. Everybody can put it in, but to get the perfect result.
Yeah, I like that comparison because sometimes we talk about flow, dynamics, these kind of things, and I mean, maybe it makes more sense that this for the flow, but finally the results are this, so I don't know, to be honest.
I believe this concept of having a very early complete seal might be actually very good, maybe also in terms of looking on the speed of cell coverage, because I think if you have this washing in and out of the device for a prolonged time, it's something that can disturb that. So that's something that could be nice to investigate more. Is an early complete seal also something that really can facilitate healing and reduce the risk of DRT? And that was what we saw with this device and also with the former Zenith device, very early rapid occlusion.
Sealing and
Yeah.
occlusion, yeah.
A question by Martin. So.
Well, just a short comment or idea. I think what we see with all these devices is that they will struggle to really do large-scale comparative trials because that's a big investment. Yeah. And we know from what has happened that really this space of LAAC is complex because of the variability of the devices. And we've seen devices where we think they were good and we're discussing this and then they didn't work because some issues like pericardial effusion. It could be a role of ELAACC actually to set up a registry where from the beginning we collect all the data with the existing devices and the other devices you know, I mean, we will not make obviously the comparative prospective studies, but at least one could fill the space because it will be interesting to, with the growing evidence that this is a standard therapy for AFib patients to get more data on all of this.
Possibly. I mean, my only question there is, I mean, it seems the device occludes, if you get it in place, it occludes really well. That's very good. But what is the rationale to work with that tether? I mean, maybe also from the company here. I mean, that tether, I mean, there was a good idea behind it, but doesn't it complicate the procedure because you're completely dependent on your implant from your sheath, yes? If you can't get your sheath in a good position, you cannot get your device in a good position because it doesn't hang on a cable like we're used to use with other devices. So, I mean, maybe it was an initial good idea, but in practice, does it really turn out to be practical? I don't know. Like, well, and do you still hold on that tether?
Well, the concept of the tether, as you said, was allow you to be able to see how the device really lives before you release it, and that our updated delivery system allows you to have a cable-like delivery and then be able to see what the tether does or how it lives before you do the final release. So what we're really working for to have the ability to deliver cable style, but then to evaluate the device on the tether before final release.
But there's one more argument, and that is that the surface of your device is completely free of any metal component that should hold a cable. So that's one advantage, I think.
I should let you answer the questions going forward.
Yeah, everything has pros and cons. But okay, time for a break, I think, coffee break, and in 15 to 20 minutes, we'll be back. We will not start later than 11:05, I think.